Hello, my name is Kaylee Dayton. I'm an ICU nurse practitioner, host of the podcast Walking Home from the ICU, and founder of Dayton ICU Consulting. I am on a mission to help create awake and walking ICUs. For context, when I started my career over 10 years ago, I was interviewing into a high acuity medical surgical ICU in Salt Lake City, Utah. The nursing manager asked me, would you be willing to walk patients on ventilators? I had no idea what that meant, but I enthusiastically said, yes, of course. I was willing to learn anything. And for years, I didn't understand how significant that question and that practice is. Because in that ICU, for decades, they have allowed almost every patient to wake up right after intubation and mobilize shortly after. It is the cultural norm to have patients writing on a board, texting on their phones, sitting in the chairs, walking throughout the halls while critically ill on mechanical ventilation, even on high ventilator settings, vasopressors. They had one of the highest acuity COVID ICUs throughout the pandemic and continued this practice, and their outcomes are significantly different than the rest of the COVID world, as well as the ICU community. There are so many reasons that I could preach about as far as why we should avoid sedation and maximize mobility during critical illness in the ICU. But in this webinar, I want to focus on the financial benefits of the ABCDEF bundle. If you are a financial stakeholder of a hospital system, you should be very engaged and concerned about your hospital's sedation and mobility practices. We know that delirium alone doubles the risk of dying in the hospital. Yet from a financial perspective, why should we care about delirium? We know that one episode of delirium increases healthcare costs by 39%. A 2004 study, so 19 years ago, they found that ICU costs increased by $9,000. Overall hospitalization costs increased by $14,000 just from one episode of delirium. They found that the length of stay with delirium in the ICU increased by 4.77 days. Hospitalization time increased by 6.67 days. In 2008, one study showed that total hospitalization costs from delirium ranged from $16,303 to $64,421 per patient. And again, that was in 2008. Another study from 2008 showed that the national burden of delirium on the healthcare system ranged between $38 billion and $152 billion. This creates a financial crisis within our systems. We also know that delirium is a huge burden on our clinicians. Delirium doubles the nursing hours required for care. Delirium is extremely difficult to care for when you have patients that are confused, agitated, disoriented, increase the risk of falls. 75% of falls in the ICU are from delirium. A recent study showed that much of the psychological stress that nurses experience are from caring for patients with delirium. So not only does delirium increase the burden and the costs within the hospital, but as it continues outside of the hospital, these new cognitive impairments or this new diagnosis of post-ICU dementia from delirium leads to an increased need in caregiving, loss of employment, and overall readmissions back to the hospital. A 2016 Australian study showed that over 10% of all dementia was from delirium. This estimated cost of delirium was 5.3 to 12.1 billion USD dollars. The USA has 13 times the population of Australia. This is a huge financial sinkhole for our healthcare system. Here's a powerful example of how sedation and delirium prolong the time of the ventilator, time in the ICU, hospital, and increase costs overall. Suzanne was a healthy 49-year-old that developed Ludwig's angina, which is essentially an infection in her neck that causes lots of swelling. So she had a breathing tube placed to protect her trachea to make sure that she could continue to receive oxygen if that swelling were to become so severe that it started to press into her trachea. That was it. She had no real need for sedation other than the cultural habit that led the team to automatically sedate her and put her into medically induced coma just because she was connected to a ventilator. During that time under sedation, she didn't sleep, right? So she developed traumatizing delirium. She thought nurses were trying to kill her, that her children were kidnapped. She was extremely terrified the entire time under sedation. So when the team determined that the swelling had improved and it was time to take her off the ventilator, probably maybe about a week into her stay, she came out extremely agitated. She was thrashing. She was trying to pull out the breathing tube. And because of the sedation culture, the team misunderstanding the cause or the reason for the agitation, determined that she was not ready to be off the ventilator and said, she's not ready, we'll try again in a few days. She had no real reasons to be on the ventilator, to be intubated, other than that because she was sedated. And she was sedated because she was intubated, and intubated because she was sedated. And that cycle continued. Of turning down sedation, she'd come out agitated, they'd resume sedation, and she ended up being intubated for 18 days. Perhaps over a week of that was unnecessary, but it was rooted in the team's failure to truly practice the ABCDEF bundle. Because she did not move a muscle during that time, she lost over 30 pounds. And it was admitted to the hospital at 130 pounds. So she weighed less than 100 pounds. And she required additional days on the medical floor, trying to regain the ability to sit, stand, walk, swallow. This is an extremely expensive and unnecessary practice to automatically sedate every patient on the ventilator. That weakness, that muscle loss alone, which we call ICU-acquired weakness, increases healthcare costs by 30.5%. So the longer we allow patients to be free of any mobility, any utilization of their muscles, the more expensive it's going to be. And this alone increases time on the ventilator. And we know that the longer patients are on the ventilator, the more at risk they are of developing complications such as barotrauma, pulmonary edema, pulmonary embolism, ARDS, as well as infectious complications such as ventilator-associated pneumonias. And the more complications they develop, the longer time they spend on the ventilator, the more costs that they accrue, the more complications they have, the more and longer they are sedated and immobilized. And this cycle continues. And this ultimately results in incredible healthcare costs as well as financial and legal liabilities. But let's look at ventilator-associated pneumonia alone, on its own. We call those VAPs. One case of VAP increased healthcare costs by $45,609. Yet we know that mobility can drastically change that. For each increased level of mobility, there was a decrease of 40% in the hazard of ventilator-associated pneumonia. For COVID patients, for overall health or hospital-acquired infections, the costs and the time in the hospital greatly varied. So for a hospital-acquired infection of any kind for COVID patients, their length of stay increased by 19 days in the hospital. Their ICU length of stay increased by 15 days. Their time on mechanical ventilation during a hospital-acquired infection increased by 15 days. This is extremely expensive. And we know that mobility, when patients are up and moving, the risks of developing hospital-acquired complications of any kind, especially infections, greatly decreases. Here's an example of how ventilator-associated pneumonia increased the costs in the ICU and in the hospital. Chris was a 57-year-old woman with a history of fibromyalgia. She was admitted to the ICU for COVID pneumonia. She was intubated and automatically deeply sedated to about a RASS of -3. She did not have any awakened breathing trials during her time on the ventilator for COVID-19. After 8 days on the ventilator, her settings were very, very low, and she was weaned down to a PEEP of 5 and 40%, which is essentially minimal ventilator settings, which should be timed to take out the breathing tube, yet she continued to be deeply sedated. Her family advocated for her to have a sedation vacation and was informed it's not safe, she has COVID, with no real evidence behind it. After 2 days of having minimal ventilator settings, her sedation was finally weaned off, and she did a 30-minute breathing trial, yet she was still too drowsy or delirious to be able to breathe on her own. On the third day of minimal ventilator settings, she was able to breathe on her own for 3.5 hours before she became tired and tachypnic, and she was re-sedated that night. Again, without a real reason for sedation, a real indication other than this cultural belief that just because patients are intubated on mechanical ventilation, that they have to be sedated. And this fatigue and high rate of breathing during those breathing trials were likely because of the weakness that she had developed, in large part because of the immobility and the sedation and the COVID. So on the fourth day of minimal ventilator settings, her family again advocated for physical therapy to work with Chris, and they were told she's not ready for physical therapy, and they would only allow her to do a 30-minute breathing trial that day. Yet we know that it is safe and it is feasible and part of the ABCDEF bundle to mobilize patients on mechanical ventilation with very few exceptions. So again, another failure of the ABCDEF bundle. So the next day, on the fifth day of having settings, she developed a fever increase in white blood cells, increased level of support on the ventilator. She was resedated again. And over the following 4 days, she developed septic shock, ultimately required 4 rounds of CPR, and died. Allowing Chris to be awake on the ventilator may have changed that significantly. Had she been awake on the ventilator, there is significant evidence to say that by the time she reached a PEEP of 5 and 40%, she would have been ready to be off the ventilator. She should have been strong enough, awake enough, engaged with an environment enough to be extubated successfully and walk out the doors. Yet because she was sedated beyond what was ever necessary, she was too drowsy to breathe on her own. She failed breathing trials, which increased her time on the ventilator. Because she was re-sedated, she continued to atrophy, have more muscle loss, more delirium. Because she was not working with physical therapy, she wasn't able to rehabilitate and be able to regain the ability to breathe on her own. And because of that extra time, those extra 4 or 5 days of sitting on the ventilator, laying in bed, likely aspirating, she developed a ventilator-associated pneumonia, which led to septic shock. So this increased ICU length of stay and days on mechanical ventilation by at least 9 days. So not only was that lethal for Chris, that was laborious for the ICU team and expensive for the healthcare system. We also know that hospital-acquired pressure injuries are extremely expensive. One study back in 2010 showed that the average hospital treatment cost for a stage 5 pressure ulcer was $129,248 during that one admission. Yet these pressure injuries usually lead to readmissions into the ICU or into the hospital in general. And we know that early mobility significantly reduces the rates of HAPI. We also know that when patients are immobilized and become extremely weak, these are flaccid American adults that are usually over 200 pounds, that is extremely expensive for our healthcare providers. We found that in the ICU that there are 6.8 injuries per 100 full-time employees. And these injuries are usually related to overexertion and bodily strain. And the average cost of an injury with each employee is $15,860. And just for direct costs to that injury, and overall indirect costs are probably 4 to 5 times that amount. We know that this is extremely dangerous, laborious, and expensive for our hospital and our care team. When patients are able to be awake right away after intubation, they can usually get themselves out of bed, at least help far more than having to turn a patient in bed, boost the patient up, lift them to the chair, help them walk. It increases the risk on our staff to allow patients to atrophy so severely that they require full support from our staff. This is a video of a patient in Brazil that is intubated and on continuous renal replacement therapy, CRRT. And the staff isn't having to help him walk. They're just at standby, helping him raise his arms. This is what the ABCDEF bundle looks like. This is how we create a process of care that is safer for our patients and especially our staff, which all decrease healthcare costs. We know that falls alone are very expensive. For 1.7 to 25 per 1,000 patient days, the cost per fall is $13,063. Falls are extremely expensive, but we know that 75% of falls in the ICU are in the setting of delirium. We know that by decreasing delirium, having a process of care that allows patients to stay awake, engaged with the environment, mobile, we prevent the development of delirium, and we can greatly prevent falls in the ICU. Even though falls may not happen that often in the ICU, our process of care within the ICU set up this high risk of falls after the ICU, whether it's on the medical floor, in our care facility or SNFs, and can create readmissions to the ICU. This all increases healthcare costs. Having patients that are that weak and confused sets them up to have falls, whether in the ICU or after the ICU. This is another patient in Brazil in 2013 walking on the ventilator. They have some standby assists with them, but she's walking. This is going to greatly decrease her risk of falling in and after the ICU. This is what the ABCDEF bundle looks like. This is the gold standard of care. We know that healthcare costs and liabilities are decreased by minimizing time on the ventilator, decreasing time in the ICU and hospital, decreasing hospital-acquired infections and complications such as ventilator-acquired complications, delirium infections, falls, blood clots, morbidities, decreasing readmissions, decreasing discharges to destinations other than home. These are our top tickets to being able to minimize hospitalization costs. And to be able to do that, to be able to prevent all of those complications or greatly minimize them, we have to practice the ABCDEF bundle. And many hospitals will say we practice the ABCDEF bundles because they have awakening and breathing trials, CAM and RAS scores embedded into their electronic healthcare systems. That is perhaps part of the ABCDEF bundle. Those may be helpful tools to systemize the ABCDEF bundle, but that does not mean that we are actually practicing the ABCDEF bundle. The ultimate goal of the A to F bundle is to produce patients who are more awake, cognitively engaged, and physically active to facilitate patient autonomy and the ability to express unmet physical, emotional, and spiritual needs. That is the A to F bundle. Every patient is different. We have to customize our care to optimize it. But when you have this overall vision and goal of having patients that are awake, even on the ventilator, mobile, even on the ventilator, then we can truly practice the A to F bundle, and we can use these individual tools to customize care. So as of right now, throughout our healthcare system, throughout our ICU community, the habit has persisted, despite their evidence to show that this is lethal and expensive, to automatically sedate every patient after intubation, keep them immobile, and then do awakening trials later once their ventilator settings are low, and we're assessing to see whether or not they can come off the ventilator. That is not the A to F bundle. When we use the actual steps within the A to F bundle to achieve the goal of having them awake and immobile, we can overcome those cultural barriers that we have currently in place in our ICUs. So if we break down the A to F bundle by each letter, A is assess, prevent, and manage pain. We do not know what our patients need unless we ask them or allow them to express their pain. When we automatically sedate patients, we're not practicing the A to F bundle because we're not able to really assess and manage their pain. I appreciate having patients that are able to write and tell me, this hurts, I need this. They can tell us when pain management is adequate, what helps, and we can work with our patients to make sure that their pain is adequately managed without fully sedating them and immobilizing them. B is both spontaneous awakening and breathing trials. Unless there is a need for sedation, we should be allowing our patients to wake up and tell us what they need. Sometimes there are indications in which sedation is absolutely necessary for survival: intracranial hypertension, seizures, the severest of ARDS or cardiogenic shock, in which patients cannot oxygenate with movement. Those are exceptions. So after each intubation, we should ask within our teams, does this patient have an indication for sedation? Is it necessary? If it is, then we'll start it, but we'll then use C, which is choice of analgesia and sedation. We will use the safest type of sedation, the lowest dose, and use it for the shortest duration possible. We will assess each day, each shift, does this patient still need sedation? Can we lighten sedation? We will constantly reevaluate in order to minimize the overall sedation and immobility the patient suffers. And this is how we practice D, delirium, assess, and prevent. If we deeply sedate our patients, we don't know what they're experiencing. We don't know if they have delirium. And especially if we automatically and arbitrarily give patients sedation without a real indication, we're not preventing delirium. We're often causing, exacerbating, and prolonging delirium. And E is early mobility. When we automatically sedate our patients, we take away the ability to practice early mobility, which is a potent tool to prevent and minimize delirium, as well as minimize time on the ventilator because they preserve the ability to breathe on their own, time in the hospital because they're able to walk out the doors of the ICU, spend minimal time on the floor, and discharge home for the most part. And F is family engagement. Again, families cannot be truly involved and have a full patient experience when they are deeply sedated. And this is another tool to minimize delirium and decrease healthcare costs and hospital complications. If we are not practicing these steps, these tools, with the overall goal of having patients that are awake and mobile in the ICU, we are not practicing the A to F bundle, and we can be held legally liable for that in the court during malpractice cases, because we know that the A to F bundle drastically changes patient outcomes. The A to F bundle decreases or increases likelihood of discharging out of the ICU and going home. It decreases the risk of death by 68%, decreases coma and delirium by 25 to 50%, decreases physical restraint use by over 60%, mechanical ventilation use is decreased, ICU readmissions decreased by 46%, which clearly decreases healthcare costs significantly. Patients are 36% more likely to discharge home. So if we are trying to decrease healthcare costs by minimizing time in the ventilator, time in the ICU, time in the hospital, and decreasing ICU readmissions, we have to practice the ABCDEF bundle. Of significant note, this study was done with almost 20,000 patients throughout the world. So there was a variation or a spectrum of application of these tools. Yet we found within this study that outcomes were dose dependent. The less sedation used, the more mobility implemented, the better the outcomes were. Each element of the ABCDEF bundle contributes to improved patient outcomes and a decrease in healthcare costs in different ways. This study looked just at awakening and breathing trials. Again, these are patients that were automatically sedated right after intubation, and sedation was turned down just enough each day to allow patients to take their own breaths. They found, just with doing awakening and breathing trials every 24 hours, that ventilator days and length of stay decreased. Vent days decreased by 2.4 days, ICU length of stay decreased by 3 days, and overall length of stay in the hospital decreased by 6.3 days. Ventilator-associated events such as barotrauma, pulmonary edema, ARDS decreased by 37%. Infectious complications such as ventilator-associated pneumonia decreased by 65%. And again, that's just by doing awakening and breathing trials. By disrupting sedation, hopefully decreasing the dose of it, outcomes drastically improved. One study showed that the average cost in the ICU per day was $3,500, and that study was from 2005. So just by awakening trials in 2005, overall hospitalization costs decreased on average by $22,000. One study showed that healthcare costs from the ABCDEF bundle decreased by 24 to 30%, depending on the level of compliance with all of the elements. We know that the ABCDEF bundle looks like this. This is a COVID patient in Brazil again, playing volleyball, probably on a PEEP of 12 and 60%. It also depends on how we treat patients right away, right after admission, which is an element that we miss within the ICU community. And let's use the example of Luke. He's a 22-year-old male with a history of trisomy 21 and autism. He had a baseline cognition of a 3 to 4-year-old. He was admitted for mycoplasma pneumonia and mild ARDS. He was intubated on cis control with an FiO2 of 80% and a PEEP of 12. In any other ICU, outside of the wake and walking ICU, he probably would have been automatically sedated. We worry about Luke's safety. Most adults, when they don't have encephalopathy or delirium, they can understand what the breathing tube is for and cope with it. But Luke was going to be different. He was not going to understand, but they wanted to treat him especially cautiously, understanding his baseline risk factors for poor outcomes. They saw the end from the beginning. They knew that if they automatically sedated him in that moment, he was likely to develop delirium, which was going to make him very difficult and unsafe to manage later on the ventilator. He was not going to be able to mobilize. He would be less likely to be able to successfully extubate, more likely to have tracheostomy, discharge to a care facility, and have many complications and probably readmissions to the ICU later. They wanted to give Luke the best outcomes possible. So they allowed him to wake up right after intubation. And as long as he had his toys, music, cartoons, a hand to hold, his parent nearby, he was okay. He was not agitated, restless. He never developed delirium or ICU-acquired weakness. He was walking on the ventilator shortly after intubation, never became a real fall risk, and did really well. After 12 days of being intubated, he was able to be extubated, and he discharged straight home. He did not need rehabilitation or a care facility, and his outcomes were completely determined by the team's mastery of the ABCDEF bundles. Here's a patient, a COVID patient from the Awake and Walking COVID ICU. He was 69 years old, admitted to the ICU, intubated. They took off sedation right away as he had been intubated in an outside facility. He was awake and walking on the ventilator for 6 days. When he got worse, he acquired pronation. He was still awake while prone for 2 days, and then got worse, in which he could not oxygenate with movement. They sedated and paralyzed him for 6 days. And when they found that he could be supine and still oxygenate well, they did an awakening trial right away. Once they found that he could oxygenate with movement, there was no longer a need for sedation. They took off sedation, and he was delirious. He was confused. He was agitated. They mobilized him promptly. in order to treat the delirium and treat his new ICU-acquired weakness, as he had lost a lot of muscle during that time of being prone and paralyzed. 4 days after being able to be supine, he was extubated. 10 days after that, he discharged straight home. For his 70th birthday, he went golfing 6 weeks after discharge. 2 weeks later, so 2 months after discharge, he emailed me to say that he'd walked 8 miles that day while golfing at 70 years old after surviving severe COVID-19. And that is because of the true mastery of the ABCDEF bundle from the Awake and Walking ICU. That alone decreased his chances of being readmitted to the hospital, tracheostomies, LTAC admissions. That process of care drastically changed not only his life, but the healthcare costs involved in his care. And that persisted throughout the COVID pandemic. We know that this is a legal liability. The definition of malpractice is improper, illegal, or negligent professional activity or treatment, especially by a medical practitioner, lawyer, or public official. The ABCDEF bundle is recognized by organizations such as the Society of Critical Care Medicine as the standard of care in the ICU. There are over 3,000 studies on delirium, sedation, early mobility, and the ADEF bundle that can be used to tie back patient harm, patient suffering, and even death back to the failure to practice the ABCDEF bundle. In court, it would be very difficult to justify automatic deep sedation, especially with benzodiazepines, lack of mobility, if we hold it up to the evidence that is available to show that patients are more likely to survive and thrive by practicing the ABCDEF bundle. And those kind of malpractice cases can be very expensive for hospital systems. Yet, there is an expense involved in having safe staffing ratios, physical therapy, occupational therapists involved in the care. And nonetheless, that is a huge return on investments. I've had teams say, we'd love to work with you. We'd love to have improvement in our practices, but we're trying to save $25 million this year. But if that is the case, then we especially should be desperate to practice the ABCDEF bundle. Clearly, it decreases healthcare costs, but the investment in therapists, safe staffing ratios is a huge return on investment. We have seen that early mobility can reduce the rate of ICU delirium by 95%. And remember, delirium increases healthcare costs by 39%. A study from 2015 from a hospital system with 1,000 yearly ICU admissions showed that the cost savings of reducing time on the ventilator and days in the ICU for ventilated and non-ventilated patients was $927,000. And again, take into consideration that this is also dose dependent. Early mobility can be very subjective. It can be passive range of motion while someone's sedated. It can be sitting at the side of the bed, standing, or walking right away after admission, even on mechanical ventilation. So costs are also dose dependent. So these studies were done with a lower dose of early mobility than was likely possible. Nonetheless, the savings are incredible. They also found that the impact of an early mobility on hospital readmissions alone was an additional $93,000 of annual savings. And again, savings are dose dependent. The more mobility, the better the outcomes, the more savings there are. A 2013 Johns Hopkins study looked at 900 annual admissions, and they found that the cost for physical and occupational therapists did increase by $358,000 that year. Yet, the early mobility that they provided to the ICU team and patients led to a length of stay reduction of 22% in the ICU and the floor. Total healthcare savings were conservatively $817,836. So by investing $358,000 in occupational and physical therapists, they decreased their overall length of stay by 22% in the ICU, 90% in the floor, and decreased and saved about $817,000. They also found that with a sensitivity analysis, if they were to extrapolate this to ICUs with 200 to 2,000 annual admissions, they would estimate that the costs are $87,611 and savings are $3,763,149. This is spending thousands to save millions. It does not make sense to continue our current process of care and not make this huge investment. A study back in 2020 in a trauma ICU showed that an early mobility program decreased healthcare costs by over $8,000 per patient. A Brazilian study from 2019 evaluated the difference in healthcare costs between having physical therapists on staff in the ICU 24 hours a day versus only 12 hours a day. They found that healthcare costs decreased significantly by having physical therapists there all around the clock. I have the understanding that many areas of Brazil legally mandate the presence of physical therapists in the ICU 24 hours a day because of the significant decrease in healthcare costs. Occupational therapy is the only spending category in which there's a significant reduction in readmission rates for diagnoses such as heart failure, pneumonia, and myocardial infarctions. Occupational therapy prevents readmissions, decreased length of stay with less complications, which all decrease in healthcare costs. So hopefully by now it is very clear that the research is vast and compelling, showing the important change in outcomes for the A to F bundle as well as a decrease in healthcare costs. Yet there are many reasons in which this has not become the cultural norm throughout the ICU community, in large part because of barriers such as culture, habits such as benzodiazepine use, deep sedation, immobility, that we had started to move past during the mid-2010s, but that re-immersed during COVID-19. Now we have a lack of education, training, experience among many of our new ICU clinicians. Leadership often does not have the perspective or vision or tools to guide this kind of change. We lack the vision of the ABCDEF bundle. We have minimal staffing resources available, accountability, systemic support. It can be a daunting task to change core culture and dynamics within a team, as well as sedation and mobility practices. This is why teams throughout the world are using Dayton ICU consulting to transition to becoming awake and walking ICUs. We can lead teams to evidence-based sedation and mobility practices through performing a gap analysis, multidisciplinary training webinars, leadership support and consulting, interdisciplinary on-site training such as simulation training and expert consulting, and building a community and outreach network that provide the tools necessary to help your team specifically master the ABCDEF bundle. Teams are reporting back with results very quickly. One team showed a greater than 50% decrease in delirium. Another team reported a 75% decrease in length of stay. They have quickly been reporting improved workload, morale, burnout workplace environment, which hopefully will result in greater staff retention and ultimately decrease in healthcare costs. So in conclusion, the ABCDEF bundle and early mobility result in significant net savings. Though it has been the cultural norm to automatically deeply sedate and immobilize every patient on mechanical ventilation in the ICU, that is an outdated practice and results in significant costs as well as legal liabilities. The A to F bundle drastically decreases healthcare costs. Early mobility has an impressive return on investment, yet the total net savings is dose dependent. It depends on the compliance with the ABCDEF bundle. Physical and occupational therapists cannot do their jobs, they cannot maximize mobility until we change our culture and our sedation practices within the ICU. The investments to facilitate these up-to-date and evidence-based sedation and mobility practices through staffing, training, and support will result in improved workplace environment, staff retention, bed flow, patient outcomes, and healthcare costs. To discuss your team's specific needs and barriers, please schedule a consultation at www.daytonicuconsulting. I look forward to discussing how your team can become an awake and walking ICU.